I think we're recording. We'll wait a little bit before we get started. Everyone hear me okay? I'm going to start checking the chat thing here, make sure everything's working. Excellent. All right, we'll just wait a little bit. We're going to be doing unknowns 120 through 129. I think we're recording, so that's good. One more minute, we'll wait. All right, well, I think we're pretty much right on time now. So 7 o'clock here in Michigan. So I think we can get started. As I said earlier, hopefully you had a chance to go over RSS 120 through 129. That's what we're going to be doing today. And without further ado, we'll go ahead and get started with number 120. It's RSS 19120. And I thought maybe since these are kind of random unknowns, I'd sort of take like my approach, like how I look at a slide and what I'm thinking about, what my differential diagnosis is, pattern approach, that sort of thing. Hopefully that'll give you some useful tips. So here is number 120, 120. And so I look at this and I notice a couple things. I mean, obviously we have a good punch biopsy. Usually start from the top down. So we see kind of an unremarkable epidermis, really not much going on there as far as spongiosis or anything. Basket weave, more or less, hyperkeratosis. So nothing really, that indicates that the epidermis is probably uninvolved. And in fact, we probably have a little bit of a Gren zone, kind of this sparing way here in the papillary dermis. So the action's in the dermis. And you can also see here, it's a little bit hard to tell because the slide is a bit on the paler side, but this is like very kind of robust collagen. It reminds me very much of young skin. You have a lot of adnexal structures and no solar damage. So it's a little bit of a kind of a softer call, but I would think, well, are we dealing with the younger patient here? So that would be on the back of my mind as well. Then we also have the meat of what's going on here, which is this infiltrate, mostly confined to the superficial portions of the epidermis here. And so I'd start thinking about, well, is this an inflammatory thing? It's kind of got this perivascular interstitial distribution. And, you wouldn't be wrong in thinking, well, is this a perivascular lymphocytic or interstitial lymphocytic infiltrate? Because the cells kind of have that lymphoid quality. But if we go a little bit closer, we can notice that the cells aren't quite right for lymphocytes. They're not that real small, round nature to them that we normally associate with lymphocytes. They have a lot of cytoplasm. And as we get even closer, even at this medium power, there's something about them, the way they kind of coalesce like this. They're respecting each other's borders. They're larger. They're just conglomerating a little bit differently than what we would expect like lymphocytes to do. And they have this very abundant sort of in between cytoplasm. Is not quite eosinophilic or basophilic. And of course the fried egg, the centrally placed round nuclei. And each cell looks like a clone of one another. Even at the medium power, you can kind of start to tell that that's what's going on. So this is urticaria pigmentosa, which is the most common clinical variant of mastocytosis, about 80% of cases. These are all very, very nice example of mast cells. Usually in this condition, which has a good prognosis in kids, you get this multiple red-brown macules or papules on the trunk. You get Darrier sign And the infiltrate usually involves the upper portions of the dermis, as we're seeing here at near the dermal epidermal junction. In most cases of mast cell disease, you can see scattered eosinophils, you can see maybe a little bit of basal layer pigmentation as a clue. I couldn't find any eos here, actually. I kind of looked, but you do have a little bit of that sort of basal layer pigmentation, so that can be a good clue, actually. So it's a nice example of mast cell, and actually I have something here. Here's a clinical photo showing what it would look like in kids, which it often presents as. And here's Darier's sign. As you know, mast cells have a ton of histamine. So if you scratch this, you're going to get histamine release and basically an allergic reaction on site. So that's what we got there. So it's a really nice example. You can think about several things in the differential diagnosis. When it's urticaria pigmentosa or even nodular mast cell disease, usually it's not much of a challenge because of what I mentioned. The histology is so characteristic for mast cells. It's really, we run into problems when we're dealing with TMEP, because it can really be very subtle. And I think I had a case of TMEP that I showed at one of my earlier talks, where it can be really, really subtle. And unless you're really thinking about it clinically, it's easy to miss. You can often think about an inflammatory condition like an eczematous process when dealing with TMEP in the differential diagnosis. Some other conditions such as Langerhans cell histiocytosis, maybe a xanthogranuloma or melanocytic lesions can all be in the differential diagnosis. But our mast cells stain very nicely for CD117 or another immunohistochemical stain, tryptase, can light these up, or you can do a chloracetate esterase, which is a good stain as well. Unfortunately, we don't have an example of that on this one, but I think I showed one before again with that TMEP case. So a good example of mast cell disease. Hopefully we got some good points on that. And if anyone has any questions on that, otherwise we'll move on to our next one. All right, nothing in the chat. So let's go on to number 121. All right, so let's see here. This is number 121. We got a couple examples of this one actually, and we can start off with this one because I think it's a better example. We have a tumor. It's very easy for us to tell. We got this large nodule, and the thing I noticed about this, a couple things at low power. It's very well circumscribed. You can almost imagine that this thing sort of shelled out, and it's got a really nice capsule here. And then you got this cellular areas here, and in the middle or in between these cellular areas, you got some areas where you see some vessels, some kind of large caliber vessels like what we have right here. And then we got the meat of what this is, which is this right here. This is actually a schwannoma, and these are all probably some of the best examples of Verrucay bodies that you're going to see in a long time. In schwannomas, you typically have the Antony A and the Antony B areas, the Antony A being the cellular areas and then Antony B being the hypocellular areas. The two examples we have here actually are kind of unique in that I don't really see a whole lot of Antony B or the hypocellular areas. Usually there's like myxoidy areas. This is almost all cellular areas, but it is in any case, a very, very good example of Verrucay bodies. So what is a Verrucay body? Basically, you got these cells that line up, their nuclei palisade very nicely, very densely, and then you have the cellular process. These kind of extend out in the area where there are no nuclei, and that's this whole structure right here is actually a Verrucay body. So you get a ton of them right here. Let me show you the other one. The surrounding area, or what the capsule that surrounds schwannoma is actually composed of perineural cells. So this capsule right here, it's one of the very highly characteristic features of a schwannoma is this capsule. And if you were to do an EMA stain, perineural stain, cells actually stain very nicely for EMA. So you would get that be nicely positive. So here's another example, a little bit paler slide. But again, the Verrucay bodies, if you see those, you've really got your diagnosis. So if you see a big goomba, a big tumor, and you're wondering what it is, you can get your diagnosis by seeing those Verrucay bodies. And again, I mentioned earlier, you can have those large vessels. This one actually has a much nicer example of these large caliber vessels that kind of intersperse the whole tumor. So schwannomas are one example of a very, very strongly S100 positive tumor. And I mentioned that because of the one variant of a schwannoma, which is the epithelioid schwannoma, which can be a little hard to identify at first. You can actually not have all that many verrucate bodies to make it easy to identify. So you can have strong S100 staining, and you can think, oh, well, this might be a melanocytic lesion. So that's one of the things one of the take-home points I want you to remember, because not everything that stains strongly for S100 is going to be a melanocytic neoplasm in all cases. But in any case, this has still very good, easily identifiable verrucate bodies. All right. Any questions about case number 121? Oh, I wanted to show one more thing actually as before we move on. So I always found very helpful difference between a neurofibroma and a schwannoma. A neurofibroma, you can imagine a cross section of nerve right here. It involves all, or contains all elements of a nerve fiber. So you'll have little nerve fibers interspersed throughout the whole thing. Whereas a schwannoma tends to be at the periphery of the nerve. So that's why you get this kind of perineural capsule, EMA positive perineural capsule surrounding it. So this schematic I always found very helpful when I was training to distinguish between the elements of a neurofibroma versus that of a schwannoma. So I hope you find that helpful. All right, let's move on. Okay, case number, that was 121, so we'll move on to 122. Okay, so number 122, we only have one example, but it happens to be a very good example of what this is. So first thing I noticed, aside from this being a punch biopsy, I'm thinking to myself, this was obviously a very pigmented lesion. You have a ton of melanophages within the dermis. You probably have a lot of tyndall effect going on that gives it that sort of bluish appearance because of the refractile nature of the light here. You get the blue that's predominantly refracted. That's tyndall effect. But the other thing I notice here, and that's one of the take-home points about this, is that we have a very wedge-shaped lesion right here. So you can imagine the point being right here, and then it kind of fans out in this direction here, and in this direction here. So it's a very wedge or V-shape, if you want to use that term. This is a predominantly dermal neoplasm. You may have a few nests along the epidermis, but mostly filling the dermis. And the other major point I wanted to make is just the histomorphology of these cells. They're very ovoid. They have a lot of this sort of neutral, most of them have a lot of this neutral cytoplasm, with the except of these interspersed, very heavily pigmented cells right here. And for the most part, very bland and nuclear features. But I want to stress that this is really a diagnosis that's kind of made at this power right here. If you have this architecture right here with all of these melanophages, all this pigment, then you've got your diagnosis of deep penetrating nevus. You can call this a plexiform spindle cell nevus. There's thought that this might be related to an epithelioid or a clonal nevus, which we sometimes see in daily practice, actually much more often than we see deep penetrating nevi. We'll see sort of regular nevi, everyday run-of-the-mill nevi that just happen to have areas that look, very focal areas that look like this, and we call those clonal nevi. So I mentioned it's predominantly dermal, wedge-shaped, nest and fascicles of spindle cells and epithelioid cells. Since genetics is all the big talk right now in melanocytic lesions, you should probably know that these have MAP kinase mutations and mutations in the beta-catenin in particular. That's a very important thing that's kind of a hot topic right now with these deep penetrating nevi. So beta-catenin mutations. Okay, any questions about this case? We are good to go here. All right. Let's move on to 123. All right. So I have a couple examples of this one. And I think we'll start with the first one here, actually. I have to spin it around a little bit. So what I notice here, we have this superficial shaped biopsy that has not much dermis in it, but mostly comprised of epidermis. And it has this sort of wavy look to it, or papillated or verrucous look if you want. I think probably papillated is the best term to use. And then you have this central opening right here. And connecting to the central opening, again, you have a papillated neoplasm. You have these very nice fibrovascular cores that are surrounded by this sort of cuboidal to columnar epithelium. If we go a little bit closer in those areas, we can see that they're full of plasma cells, actually. Most of these are plasma cells. And the cells that are lining these are actually showing a little bit of what's we call decapitation secretion. It's not the greatest, but if you look at some areas like this, maybe right here, you can sort of see that they're just losing the top of their head, so to speak. So that's a sign of decapitation secretion or apocrine secretion. So this is a nice example of syringocystadenoma papilliferum, which usually occurs on the scalp or forehead. And for the reasons I just mentioned, it's a disputed histogenesis, but probably most of these are apocrine in nature. You'll often see an organoid nevus or nevus sebaceous of Yatsen in conjunction with this in probably about a third of cases. In fact, that's probably what's going on right here. Although we have such a limited biopsy, it's hard to tell that if there's a nevus sebaceous next door. But on this next one, actually, I think we can see it a little bit better because we can see a much larger biopsy. And here it is the syringocystadenoma. Again, this very nice papillated architecture full of inflammatory cells, most of which are plasma cells. And if we look away from the actual neoplasm, we can see that we got slight papillation over here of the epidermis, just like in our last example, and these nice follicular sebaceous units that are attaching directly to the underside, which in normal skin you wouldn't expect to see. So they're dysmorphic is the term that's often used. And this is probably a nevus sebaceous right here, and we got the syringocystadenoma that's occurring in conjunction with that. So there's a couple other neoplasms that have this sort of papillated look to it. A couple other adnexal neoplasms. When I see this pattern, I often think about hydradenoma papilliferum, which has a very similar sort of appearance, except it's within the dermis and lacks really any kind of significant connection to the overlying epidermis. And erosive adenomatosis of the nipple can also have a similar histologic feature. Both of those are probably apocrine in nature as well, which would make sense. Okay, it's a nice example. Here's more of that nevus sebaceous over here. You can see the direct connection to the epidermis of these sebaceous units, and more of this papillation over here as well. Okay, any comments, concerns about this? All right, good. All right, so we'll move on to 24. Okay, 24 is a good one that they love to ask you on your exams, so it's a good one to know. So at low power here, it's going to be fairly easy for us to tell that this is probably a dermal neoplasm. You have a big expansile nodule right here, a lot of blue cells, but also kind of this peculiar sort of arrangement of these cells in kind of this what I would call maybe trabeculae here. There's a lot of cystic degeneration. You got some hemorrhage. You got maybe even a thrombi. I think this big thing over here is probably a thrombus. It's kind of got that pink fibrillar look to it. So if we go a little bit closer into the actual tumor, we can see you have two cell types. You got the outer smaller cells and you got the smaller or the inner larger cells. And the second example actually shows more of what I think is even more important. If we look here, here's another example, big blue globs in the dermis, and then you see this two cell types, and in addition, this intervening very pink hyaline-like material, which if we were to do the PAS stain, would be positive. So it's PAS-D positive material. And so these are aspiradenomas, and one of the painful tumors, and we've gone over this before, I think many times. Angel is my favorite mnemonic, angiolipoma, neuroma, glomus tumor, eccrine spiradenoma, this one, or leiomyoma, but there's all sorts of other ones. And I thought this was kind of a funny, I don't know, funny, but actually kind of an interesting way of approaching that. This group came up with this mnemonic: calm hog, fled pen, and gets back. Apparently that's from Charlotte's Web, but they would go through a very, very exhaustive list of things that can cause painful tumors. You know, after you read this, you think that everything can cause a painful tumor. So, but it's interesting. If you want that, this is being recorded, and we'll link all of this on our website if you're interested in looking at that later. So as you may know, these are associated with the Brooks-Spiegler syndrome, where you can see cylindromas and trichoepitheliomas. For your boards, that's the CYLD gene involving chromosome 16. And these can have, as we saw in the first example, large areas of stromal degeneration, hemorrhage, as we see in this example right here. Okay. So that's our spiradenoma. Oh, one last thing before we move on, the difference between spiradenoma and cylindroma. It's an architectural one. The cells are essentially the same, but some people are just kind of advocating the idea that we should call these things spiradenoma / cylindroma because you see so much overlap between the two in one sample. But basically, if it's more these kind of separated blue globs, you call it spiradenoma. If it has more of a jigsaw pattern, which this, I don't know, you can kind of imagine this is starting to get there, you would call it more of a cylindroma. So that's kind of the approach. Okay, any questions about case number 124? If not, we can move on. All right, we'll go on to 25. So on case number 125, this is one of these gimme cases that are fairly easy, I think, and very likely because of that to be on your board exams. You got a very nice polypoid lesion with a central fibrofatty core and these very nice sort of vellus hair follicles or follicular sebaceous units that line the whole surrounding epidermis here. So often we'll have, I think, we'll have a cartilaginous core, which that one did not, but this example right here seems to be the inverse of the last one I just showed you, because this one has all of the cartilage with not much of the epidermis. I'm not sure what happened to the epidermis here. It looks like it kind of got folded over or who knows what, but you can kind of still see these follicular units sort of lining the whole thing, and the polypoid nature of the structure and the fibrofatty core that we see right here. So by now you know this is an accessory tragus, usually present at birth in the preauricular region, anterior to the sternocleidomastoid. I'm not going to be able to say that. Here we go. Sternomastoid muscle. We'll say it nice and short like that. But here's a clinical example right here. And I wanted to also show you this article because they talk about the different faces of these three entities, the hair follicle nevus, the trichofolliculoma, and the accessory tragus. Basically, it's very hard to distinguish these three on histopathology alone. But they do say that the clinical, you really need the clinical, and accessory tragus will have a cartilaginous core. Hair follicle nevus is the one really that you should think about because that's the one that's going to more closely mimic an accessory tragus. But could I tell the difference between the two just based on histology alone? Well, maybe if I had the cartilaginous core, which in this case, actually it's missing. So I think the point of that article was that it's very hard to tell the two. And then trichofolliculoma, actually, I'm going to show you an example of something else right here in a minute that is kind of related to that. So we'll hold off on that. So accessory tragus, I just learned, can be associated with Goldenhar syndrome. There's hemifacial macrostomia. So that's something to know for your board exams as well. All right, any questions about case 125? Okay, good. So we're about at the half hour, and we're about a little over halfway through, so we're good on time here. All right, so let's go to 126. Okay, I'm going to start with the second example of this one because I think it's a little bit of a better example. Okay, so here's a punch biopsy where we have this central, what looks like an epidermoid cyst. If you kind of ignore what's surrounding it, you got this squamous lining, you got some laminated keratin, but then you see these surrounding structures that are radiating from it. And if we look close at them, they're really mostly sebaceous lobules, mature sebaceous glands. So we have two things that would come to mind for me. One would be a trichofolliculoma, and the other is what this is, which is a folliculosebaceous cystic hamartoma. So there's the idea now that folliculosebaceous cystic hamartoma is basically sort of the mature stage of a trichofolliculoma. As you know, a trichofolliculoma will have the same cystic structure, but it'll have more of these sort of like the baby hair follicles that kind of surround the cyst, whereas this one will have more of the mature sebaceous glands. So this is thought to represent more of the involuting stage of a trichofolliculoma. So that's kind of an easier way to remember it. So that kind of ties in with what we were just talking about with the accessory tragus. In some cases of these folliculosebaceous cystic hamartomas, you can have quite a bit of a stromal component. So in this one, you can imagine you don't have the greatest cystic component right here, but you can imagine maybe this area right here at some point was more cystically dilated. But we do have quite a bit of a stromal proliferation over here. A lot of fatty tissue, a lot of what looks like either fibrous or maybe even sort of a hint of a neural quality to this. You can have some a vascular element to this. So this is not too uncommon in folliculosebaceous cystic hamartoma. And in some cases can overlap with something called a neurocystic hamartoma, which we won't talk about, but it's just for completeness sake, I'll mention it. So these, if you wanted to do a CD34, you could highlight the stain, but you really don't need to do it to, as far as diagnostic purposes. So these are more common on the face. I was just actually talking about how this would open up to a cystic structure, and here we go. It's a little bit better on this section right here where it actually does open up, and it looks more like the conventional folliculosebaceous cystic hamartoma that we're talking about with a lot of the mature sebaceous glands surrounding it. Okay, questions about case 126? All right, let's go on to case 127. Okay, this is a good one for board exams, I think, because it's such a characteristic pattern that it's really easy to get it confused with something else. So we have a dome-shaped lesion, got probably a little bit of epidermal lichenification, and then we got this sort of the classic term, either plywood or hypocellular. And this area right here is really where everything lies, the whole diagnosis of this lies. This is a sclerotic fibroma, and you sort of get this whirling. I kind of think of it a little bit as a little bit of a story-form pattern, except you don't have any cells. This is sort of these empty cleft-like spaces, and you look into them, this is just all collagenous tissue. There's really no cellular tissue there, except maybe for the edge here, and I'll come back to this portion in a bit. So this is a really good example. Here's another one where it's a little bit more on the fibrotic side, even more than the last one. Slightly more difficult to make out that sort of whirling pattern, but you kind of get the impression right here that you have that sort of plywood swirly pattern, but much more collagenous. And the important thing to recognize is because in this case of sclerotic fibroma, which is what this is, in multiple cases you can have association with Cowden syndrome, which is that P10 associated syndrome that has association with breast and thyroid cancers, GI polyps, hamartomas, trichomomas, and these are sclerotic fibromas. So this is thought to be a neoplasm, although in some cases you can actually see this next to inflammatory conditions like folliculitis, and in fact, and dermatofibromas. And in fact, I thought here, even in this area, the more cellular area that I'd said I'd come back to, kind of reminded me a little bit of a dermatofibroma. It sort of had that little bit of that story-form pattern, that busy dermis pattern, and it happens to be right next to the sclerotic fibroma. So it's kind of interesting. You wonder if this, at some point in its life, was a dermatofibroma. But I think for this one, I think the best thing to call this, because it's the plywood features is such a predominant thing, would be to call it a sclerotic fibroma. So I think that's what we would call this. There's a possible relationship to pleomorphic fibroma, so that's one thing to know. And differential diagnosis, other spindle cell things, but I think if you see this, it's really, really hard to kind of mistake it for anything else. So, okay, any questions or issues about this one? All right. Let's go on to 128. All right, this is a pretty good example of a couple of examples of this one. So we have here a shave biopsy, which has a lot of these spaces within the papillary dermis. But in addition to that, you also have a little bit of epidermal involvement too. You have a slight papillation to the epidermis, some elongation of radi ridges, and it's kind of intimately associated with the papillary dermal vascular process, which is what we have here. If we look closer to the vascular process, you can see that it has this very thin wall vessels, and in particular, these valvular structures right here. It's a very nice example of a lymphangioma. Residents often ask me if lymphangiomas can have blood in them or if it's just always lymph, and the answer is they can have both. So this is probably lymph right here, this sort of proteinaceous kind of amorphic material. And then you also have a little bit of what looks like blood over here. So it's not uncommon to see both. Sometimes you can see a little bit of sort of lymphoid tissue, a little bit of germinal center formation or something like that. Although this one, in either of these cases, I don't think we had that, but that's okay. This is a fairly recognizable tumor. And you can see right here, in fact, with the involvement of the epidermis and then with the vascular structures, you can almost think about like an angiokeratoma, although that usually have much more epidermal involvement, much more of the keratoma part compared to a lymphangioma. So there's two types. Generally, they're broken down. Lymphangiomas are broken down into two types, the superficial and the deep type. Lymphangioma circumscriptum is the other name that we can use for this. And there's a term clinically called frog spawn, which is what is used to describe the clinical appearance of lympangioma. Here's actually a picture of it. And I suppose that's what frog spawn looks like, but I thought it was kind of an interesting appearance to it. So you can have multiple of these. They can have sort of a linear arrangement too clinically. It's good to remember. Some of these superficial lymphangiomas can actually connect into the deeper ones. You can have a deeper component. So it's important to know that if you're trying to excise these, you may not get the entire thing. What else? So if you want to do immunostains, the kind of the marker of choice for lymphatic vessels is D240. It's a very commonly used stain. It's used for other things as well, besides marking lymphatic origin. But you rarely need it because the histology is so good when you get this two elements. You get this papillated epidermis and you get these dilated thin-walled vessels, especially when you get these. For me, I think these valves are so helpful when you see these. But very, very bland endothelial lining. You may, if you just get this portion, you may start to think about other vascular processes like maybe like Kaposi sarcoma, but Kaposi's would not have any kind of involvement of the epidermis as in this fashion, what we see here, this kind of intimate association between the two. Although there is a lymphangioma like Kaposi sarcoma that you should be aware of, but you should have elements deeper to this that would be more classic Kaposi sarcoma before you would make that diagnosis. Plus you do your HHV8 stain. Okay, anything else on this? Any questions or concerns about any of these two slides here? Okay, we'll go on. And we are at our last one actually. So we'll go on to 29. All right. So on this one, as we flip the slide, what I notice here is a couple things. It's an epidermal process. We have a very thickened epidermis. We had a lot of hyperkeratosis. And that same sort of papillation that we were seeing earlier. We're missing follicular sebaceous units. So, and we have a lot of eccrine glands. So I would think maybe we're dealing with acral surface or something like that. And then of course, the last thing that's the most prominent, at least to my eye right here, in addition to this papillated epidermal thickening, you got this sort of pointing inward of radi ridges on this side and on this side to give you this overall kind of cup-shaped appearance. So that's one thing that you look for verruca vulgaris of all kinds. Any kind of HPV verruca vulgaris, you're going to think about if you see this sort of cup-shaped pattern. We're not going to stop there because we have other features here that kind of make this more of a distinctive lesion. We have a lot of this purpley stuff and vacuolated stuff. So the purple stuff is keratohyalin granules, and they're just really, really clumping together. There's just a lot more of them than what you would normally have in any kind of regular epidermal process. And then you have vacuolization up here. And these two, if you combine them, this is what you see in palmoplantar wart or myrmecia. I think we've actually shown another example or two. So residents always ask, or not always, but often ask, is this what coilocytes are, these kind of purple things? They're not actually. The coilocytes are the nuclei themselves. So if we go away from sort of that busy area and we look for nuclei that are kind of by themselves and have that crinkly look, like this guy right here, or this guy right here with the surrounding clearing, that's the actual coilocytic change. And all the surrounding stuff, we can still see it here. There's purpley clumped keratohyalin granules. These are all keratohyalin granules that define what this myrmecia is. So for your board exams, these are often associated with many HPV types, but in particular with one, HPV1, and you can also have association with HPV4 as well. In addition, again, to many, many other ones. But I think HPV1 is actually the strongest one. So this is another one of these that they can easily show you on your exams because it's so characteristic, and you should be able to diagnose this as myrmecia. So why is it called myrmecia? Well, myrmecia is actually a genus of ant. I didn't know this. And you have, it makes ant hills and they burrow holes. And I guess clinically, that's what this looks like. So that's where the term comes from. It's a little bit of a, sort of a trivia right there. And since this is the last case, we'll go ahead and end with a picture of this ant right here. Apparently this is from the genus Myrmecia. Sorry, I hope it doesn't give you nightmares or anything tonight, but I thought that would kind of bring the point home. So that was the last case. And does anybody have any other questions or concerns or anything to discuss on any of the cases that we just went over? You just put in the chat comment or just chime in if you want. If not, then we'll go ahead and call it an evening, and I hope this was helpful. And you're very welcome, and have a great rest of the weekend. Thank you, thank you. Glad you enjoyed it.